welcome. Thank you for joining me. If you are confused about weight, your weight medicine, weight topics in general, you have come to the right place. My name is Dr. Meghan. I am a board certified physician in internal medicine, lifestyle medicine, and obesity medicine, and I'm also a certified life coach. So let's talk about all the great questions that you have asked today. As a side note, if you want to work with me personally, if you are personally confused about your weight, we can definitely work together. I'll leave that information down below. But let's get started on today's questions. So first question. Oh, also, I'm just going to add that I can't answer personal medical questions on this live, but I will try. If you've sent in a question it seems a little too personal, I'm going to change it a little bit so it's more applicable broadly, because this is about medical education. Okay, so these are medical answers to your weight questions. All right, first question is with regards to skipping. Oh, also, please excuse my voice. I'm just getting over allergies. It's really bad, so thank you for your patience. First question is with regards to skipping doses. The video about skipping doses. Okay. I started last year and updosed too quickly. My doctor warned me, but did allow me to bump up quick. I had side effects and ultimately ended up not being consistent. Just started and I'm at the 0.5 milligram dose. Will be going up slowly. I noticed pretty quick weight loss when doing the low doses, but not much on the higher doses. Have you seen people stay at a low dose and still see similar results? This is a great question. It is a little tricky because when people are kind of bouncing around a little bit, because of the shortages, which, we're in make it work time, right? So it's sometimes hard to say like what's normal. Some people do have pretty significant weight loss in the beginning. If someone has really drastic weight loss in the beginning, I usually will wait to go up, because I don't want to overshoot the mark either, right? If I'm working with somebody on their weight, we want them to lose weight. We don't want them to lose weight forever. So there's a particular goal we have in mind. If it seems like they're going to get to that goal, or if they're losing weight really quickly on like the starting dose of a GLP-1 agonist, I generally might give it 2 or 3 months before going up again. This is if all supplies are available and there's no kind of access issues. So yes, I do occasionally have patients that lose a lot of weight on a low dose. More often what I see is kind of pretty gradual weight and more weight loss at the middle to higher doses. And everybody's different. So sometimes people are going to lose, a more significant amount on one dose, then it kind of plateaus, then it drops off more. Like there's really no rhyme or reason to it sometimes. And so you always want to make sure that you've ruled out other things, like that there's no undiagnosed medical condition going on, that you don't have medications that are interfering with your, if you're on a GLP-1 agonist, that there aren't, you're not on like a super high dose of gabapentin or something like that. But yes, I think some people, occasionally will lose a lot of weight on the lower doses, but I don't often see like a lot of weight loss and then it kind of tapers off with the higher doses. There's always people that are the exception, but that is a little unusual. But again, if people are kind of moving around a lot with the doses, it's also a little bit harder to track linearly. Okay. So this is a question about, this is a follow-up to another Ask Me Anything video that I did. What are the reasons to up your dosage regarding Zepbound or Mounjaro? Well, traditionally, I will always try, the goal is always to get somebody up to the highest dose. So on Zepbound, you start at the 2.5, your ending dose is the 15. My goal is always that we're going to eventually end up at the 15, 10 or 15. Some people don't have too much of a difference between the 10 and the 15, but it's always my goal that we're going to go all the way up to the top. That's going to give you the best chance at getting the greatest benefit from this medication. So if you're tolerating the medication well and we can access all the doses, and you're not having a lot of significant side effects or anything that's going to prevent a pretty regular progression up, then we'll just keep escalating up. So normally it's like every 4 weeks you go up a dose. Now, again, if your trajectory is very sharp at the beginning, you might want to back off. If you have a lot of side effects at the beginning, you also might want to back off and go up slowly. It's not a race. You're going to be on this medication forever. So it's not like in the scheme of your life, 1 month versus 3 months is going to make a huge difference. But in general, that's how it is prescribed, to go up every 4 months or every 4 weeks. Okay, next question. This is okay, I'm going to make this one less personal. Very good questions, though. For people who have hypoglycemia or are not diabetic, are they a candidate? I would be very hesitant to prescribe this to somebody who has hypoglycemia. And I would also wonder why they have that and they don't have diabetes. So, and again, sometimes this is, there's other endocrine issues going on. They're on different medications. That would definitely be a longer conversation if somebody had hypoglycemia. Really depends on the person and why they have it, if this would be an appropriate medication for them. Follow-up question is, for people who have reflux, would they be a candidate? That is another great question. And I will say that reflux can get better and or get worse on this medication. So because it's slowing down the movement of food through the stomach, there's longer time, the food is in the stomach for longer, so there's more time for it to go back up. So you might be, so if you have really bad reflux to start with, you may find that this medication actually makes it worse. However, you may also find that this medication, as it produces weight loss, makes your reflux better. So, or it could be worse in the beginning, and then as you lose weight, it's getting better. So I don't think of reflux as a automatic contraindication to something like a GLP-1 agonist like a Wegovy or a Zepbound. But it's definitely something that I want to review with somebody and make sure they know, hey, listen, this could get a lot worse. This is the plan if it does. But it also could get better because especially for people who have a lot of adipose tissue or fatty tissue around the abdomen, when they lie down, that's pressure, and that's pressure, intra-abdominal pressure, pushing the food up. So if you're relieving some of that pressure, then there's a good chance that the reflux is not going to be as bad. So for those reasons, I think it's also definitely worth trying if it's the right person and if they are aware, it's all about benefits and risks. So as long as they're aware of, what could happen and the physician feels like it's safe, then that might be somebody who might be a really good fit for. And they might get a lot of relief eventually from the medication. That is a great question. Okay. All right, so last question is, have you encountered the use of phentermine and Adderall to curb compulsive eating in individuals with hyperphagia? Okay, so hyperphagia meaning like overeating, essentially, can't stop eating. This is the interesting point that the person asking the question has brought up, because both phentermine and Adderall are stimulants. So I have a lot of patients who are taking something like Adderall or Concerta or Ritalin, and they find that it really impacts their appetite even when they weren't looking to lose weight. So there's certainly an appetite suppressant factor with those medications, which is really more of a byproduct. That's not why people are taking them. The exception to that rule is Vyvanse, which is also generic now, PS, which is FDA approved for binge eating as well as attention deficit issues. So I definitely will use Vyvanse for patients who have binge eating. I think it's really helpful for these patients. If someone is on Adderall, usually I would try to, really depends on the patient. I mean, let's say someone is taking, 5 milligrams of as needed Adderall. You could, and they're amenable to starting Vyvanse, which is more longer acting. That might be a good fit for somebody. Excuse me. I probably wouldn't use like phentermine and Adderall and Vyvanse together. That seems like kind of a recipe for disaster. That's 3 stimulant medications. Not a great idea. But you certainly, like people can treat ADHD with a long-acting and a short-acting. You could certainly have a longer-acting weight medication like Vyvanse at play, even if you were on something like Adderall. I would never use Adderall itself to help with appetite suppression. Adderall, is really, I would only use that for what it is intended to be used for, which is ADD and ADHD. I would never use that off-label for weight. You also have to be careful with phentermine and Adderall. Phentermine is a stimulant medication. You can, it really depends on the person who's on, and the dose of the Adderall. I guess I wouldn't say never, but I would be cautious. I would be very, very cautious. To have a really good case to use phentermine and Adderall. Yeah, and there's so many different in phentermine you're supposed to use every day. And so, if somebody's already using something like Adderall every day, that might cause somebody to have a lot of side effects. I don't know. That's a rare circumstance when I would use both of them, and it would have to be really the right person. We'd have to have a really good cause, and we'd really have to make sure that there was nothing else that could be used. So the short answer is probably not would I use phentermine and Adderall. But I certainly would use Vyvanse to help with binge eating. And if somebody was using Adderall, at the right dose, you could potentially find a safe, happy medium for somebody. So the short answer is phentermine and Adderall together, probably not. But there are ways to combine some of the stimulant medications safely, but I would say it's a very case-by-case scenario, and I wouldn't do it often. It would have to be the right person. And also, if I am acting as the obesity medicine specialist and they have a PCP or they have a psychiatrist, that's definitely somebody that I'm getting on board as well to talk about that and make sure that we're all on board with the plan. So it would be rare that would happen. I would never say never, but it would have to be really really beneficial to the patient. So yeah, that's a great question. Thank you all so much for watching. As always, you can watch this on my YouTube channel, Weight Medicine with Dr. Meghan. Thank you again, and please be well.